Hey everyone, welcome. We are seeing people popping into the lobby now. Just give us a few minutes. We'll probably officially start in about 2 or 3 minutes here, but I'm going to be admitting people into the chat and we will go ahead and kick it off with Destiny shortly. Thank you so much for joining us. For those who just popped in, welcome. We are going to be admitting people into the waiting room and we're going to get started in just about a minute or two here with Destiny's presentation. But feel free to take a minute, grab your coffee, and get ready. We'll get started in about a minute or two. Seem to be slowing down a little bit as participants come in, but we'll still probably give it about a minute. Okay, just some logistics really quickly. All participants are going to be muted with camera off. Those presenting are going to be the only ones who are able to unmute and put their camera on, but the chat should be accessible to everyone. So throughout the presentation, if you have any questions or need to talk to us, I'm going to be monitoring the chat and we'll be able to bring your questions in during Q&A sessions, as well as be engaging in the chat around the content. So if you try and unmute or put your camera on, and unfortunately it will not work, but feel free to put anything in the chat that you need to. And if anyone needs to come on camera, just feel free to chat me personally and I'll give you access to do so. I'm going to go ahead and let this last batch of people in, and then Destiny, I will pass it over to you to get started. Okay, go for it.
Okay, thank you. So hi everyone, welcome to our Medicaid Doula Pilot Findings webinar. We're so excited to have you all here. My name is Destiny. I'm a research manager here at Healthy Mothers, Healthy Babies. So excited to present this to you all today. Like Madison said, we will have some Q&A sessions twice throughout our time today, but if you have any questions in the meantime, please feel free to drop them in the chat as we go along. So just agenda of what we'll be talking about today. We'll do some welcome and introductions, a pilot overview. We'll pause for a Q&A based on our implementation, and then I'll present the pilot findings and then do another Q&A based on the findings from the evaluation side. We'll talk about some current doula research here in Georgia, and then we'll do some closing remarks. So again, welcome everybody. If you could put your name, your title, and what brought you here today in the chat so we can get to know who's here, get to know what brought you here today to this webinar. Yeah, if you could put that in the chat, we'll give everyone about 2 minutes to do that. If you are just coming in, welcome, welcome. We're just doing some welcomes and introductions in the chat. So if you could just put your name, your title, and what brought you here today to this webinar, that'd be amazing. We're going to give it about 2 minutes and get started.
See, we have a really broad kind of section of people throughout the state in the Stone Mountain area, a handful of doulas, some other providers, speech language pathologists, managers at other coalitions, and we're even looking outside of the state of Georgia. We've got some people from Indiana, from Washington, a wide breadth of people. So it's really exciting to have you all here with us today. Thank you so much.
Going to give it about 1 more minute or so, then we will get started.
So we have a lot of the participants who helped us with this pilot. So thank you all for coming. Kanaya, Fozio. I'm excited to see everyone here and excited to have you all here to present this.
All right, so we will get started. Can everyone see and hear me? Or Madison, you can let me know if you could still see and hear me.
You're good.
Okay, perfect. So yes, we will get started. We really want this to be interactive, so please drop any questions, comments in that chat. We will have Q&As again, and then yeah, we want it to be interactive. We'll pause. We might ask you a question. So let's get started. The first thing I want to do is just uplift everyone that helped with this project. This could not happen without anyone listed on the screen. I'm sure there's people that aren't listed here, but I really just want to lift up everyone. It really took the team to get this done into where we are. So I want to shout out to Kai, our amazing CEO, Precious, Chanel, which we'll talk to a bit later during our Q&A, Deandra, Selena, and Lineari. Also on our evaluation side, Madison, Tunwa, Fozio, and Dr. Elizabeth Mosley, which we consulted, and also to all the doulas and the birth givers that made this possible. Just want to uplift everyone and say thank you so much for everything you did to contribute to this pilot. And then we also want to thank our partners, our incredible partners, Amera Group, CareSource, Healthcare, Georgia Foundation, United Healthcare, and Georgia State. So thank you to all of our partners and collaborators with this pilot. So let's get started. Let's get into some background why we did this pilot. So I want to first talk about the Georgia maternal mortality rates. This is from 2018 to 2020. And we see here on the left these leading causes of death. And the main are hemorrhage and mental health conditions. And we'll talk about mental health a little bit throughout the project and when we close. But just want to highlight here that mental health is the second leading cause of pregnancy-related maternal deaths here in Georgia. All pregnancy-related deaths, with the exception of embolism, were preventable, and even 83% of those were preventable. And then also we have a breakdown by Medicaid recipients, and that's important because that is our target population for this pilot. So we see that 68% of pregnancy-related deaths after delivery were attributed to Medicaid recipients. We also see a disparity here between non-Hispanic Black women and white women. And so we see that 48.6%, 48.6 pregnancy-related deaths were among non-Hispanic Black women and 22.7 were among non-Hispanic white women. The next, we'll talk about some of the infant outcomes. So, according to the America's Health Rankings report, Georgia ranked 44th in infant mortality, 47th in low birth weight. And then next, we want to talk about poor access to care for Georgia families. So on top of some of those disparities and rates, we also want to talk about how that's impacted by access to care. And so 38 OB units closed from 1994 to 2020. And so we have 159 counties in Georgia, which was very new to me, learning how many counties are here in Georgia. But of those 159 counties, there's only 74 open OB units. And as you can kind of see by this graph on the left that shows the shortages of providers and closed units, a lot of those units are populated around those metro areas. And so just talking a little bit about rural counties and their access to care, 93 rural counties do not have a hospital and delivery unit, meaning that a lot of the birth givers in these rural counties are really having to go outside of where they live to make it to a hospital to deliver. So 2/3 of rural birth givers had to travel outside of their home county to give birth, and also no rural counties have maternal fetal specialists. So it's really important while we have these conversations to look at the access to care for birth givers and their families. And next, well, I kind of showed it, but really quickly, I want everyone to put in a chat, what they think a doula is. Like if someone asked you in your own words, how would you describe a doula? What would you say? So just put that in the chat. I'll give everybody about a minute. Madison, let me know how that's looking. But just want to get a sense of what everyone thinks a doula is.
I'll read you the best answers that come through.
Cool. And I know there's doulas on the call. I can't see the chat, but I'm sure you guys are all going to have some really amazing definitions.
So we have support for a birthing person, a bridge builder between families and clinicians, birth educator. All right answers so far, in my opinion. Non-medical support person during prenatal care, labor and delivery, and postpartum. And feel free to say in the chat, like, I don't know yet. And that's why you're
Yeah.
here. That's very possible.
Yeah.
Great. Things are slowing down, Destiny. I would say go ahead and take it away.
Okay, so we'll go to our definition that we have listed on our website here, but like Madison said, they all sound like really amazing definitions. And so we have here that doulas are non-medically trained community care workers that support people during the full spectrum of pregnancy, preconception to birth, to abortion, to miscarriage, to adoption, to postpartum. They also actively practice being open and aware of the diverse reproductive needs and experiences people have in light of their identity, background, preferences, lived experiences, and so on. So we thought this was a really great comprehensive definition of what a doula is and just really sets the stage for everything else that we will talk about. And so benefits of a doula, they have so many. We're just going to go through a few, but some of the evidence-based ones are assisting with planning to help parents make informed decisions, providing resources, and connecting families to additional support. I heard like a comment about being a bridge, and they really can be that bridge and offer additional resources and support, facilitate communication between families and their healthcare team. Some of those clinical benefits include reduced use of Pitocin, reduced likelihood of C-section. Some of the emotional benefits include decreased anxiety, improved postpartum mental health, and then some of those physical benefits include comfort and reassurance and providing lactation support. And this list could go on, but just wanted to provide a few of the many benefits that doulas provide. And so now we come to our pilot's purpose. And so the purpose of this pilot is to expand access to more holistic perinatal services and identify paths to sustainable Medicaid and other insurance reimbursement models. And so we see that research suggests that doulas offer many great benefits, and those benefits may even be greater among underserved populations. However, a lot of the times it's harder to get doula care to underserved populations for many, many reasons. But we see that expanding access to care for underserved populations can really help improve maternal and infant health outcomes, a lot of those outcomes that we talked about in the beginning of the call. And here in Georgia, 46% of births were financed by Medicaid. So it's a huge amount of births that were financed by Medicaid. And we really chose to focus in on this population as they may be underserved and in need of additional services, and also because it's such a large population of birth givers here in Georgia. And so, what other states have done? Some states are actively reimbursing, and those states are listed here. We have some states that are in the process of implementing Medicaid doula benefits. They're listed here. And then here's us with some action taking that is adjacent to benefits, and that includes this pilot program. So excited to be here. And then we also have some action taken, but no progress in some states. And so this just gives us an overview of what this reimbursement model looks like here in the nation. And so now we'll go into pilot overview. So just want to list out the goals and objectives of our pilot. The first is to examine the relationship between doula care and maternal infant health among Medicaid recipients involved in the pilot living in the state of Georgia. Our next goal is to understand the process between Medicaid reimbursement systems and the impact on doulas' economic security that participate in the pilot in the state of Georgia. And then we have two objectives under that. The first is to establish an effective doula reimbursement system, recommendation through Medicaid in Georgia, and then also to increase the number of doulas offering services and care through Medicaid. So our recruitment plan. So we posted this beautiful flyer that you see on the right, and we really reached out to see what clients will be interested in receiving doula services. This was free of charge, and so just want to list out some of the inclusion criteria for clients, and that included that they must be pregnant and no more than 33 weeks gestation, willing to receive up to 5 doula visits, and we'll talk a little bit about the model of care they provided in a bit, and then a delivery date before April 1st, insured by Medicaid, and being able to consent to participate in the pilot. And then our recruitment, 65 clients were referred to us by our partner AmeriGroup, and then 110 clients were recruited through marketing, partnering with the other partners that I mentioned in the beginning, advertising on our websites, reaching out to different organizations and providers, so much to get all the clients that we had involved in the pilot. And then we'll talk a little bit about doula recruitment. And so that flyer is here as well. And just reaching out to the network of doulas we knew, searching like every doula directory, social media advertising, really trying to pull in doulas also that were trauma informed, that provided trauma informed care and culturally competent services, and also bilingual. And then we have our matching process. And so we'll talk a little bit about the application and the doula forms in a bit, but just wanted to give an overview of how we match doulas with clients. So clients filled out an intake form that had information as far as when their delivery date was, where they lived, and things like that. And then doulas also filled out an application that included the areas they were willing to serve, where they were certified, things like that. And so Chanel, who was super wonderful in this process, really took it and did wonderfully to make sure she matched clients and doulas. And so matching them based on where they were, some of their preferences, like if they wanted care virtually or in person. And so she would match them together. And then the doula would reach out to the client within a few days, and then the doula would begin to offer services. So the matching was very intentional. Um, and yeah, they provided those services. And now talking a little bit more about the services they provided. So our model of care was doulas provided 2 prenatal visits and were compensated $50 per visit. And during those prenatal visits, there was discussion about any concerns that they may have, pregnancy concerns, any preferences they may have. They also cultivated a birth plan with their clients and provided any referrals. And then labor and delivery support was compensated at $500, and they really helped facilitate communication between the client and the hospital staff, offer any comfort techniques, and advocating based on the client's preferences. And we'll hear a lot about that from client testimony that we'll talk about in a bit. And then postpartum visits, they did 2 visits, $50 per visit. And here they provided some breastfeeding support, some physical and emotional support for the family, and also referrals. And so we see here, based on this model of care, that we were able to reimburse at $700 for this comprehensive model. But we see that in Georgia, there's been some additional doula work that we'll also talk about in the end. I know I keep like foreshadowing what we'll talk about later. But there's a Georgia doula study that's been taken on by Dr. Mosley in partnership with us and with Emory, and it came from our Doula Access Working Group. And they're doing some amazing work to learn more about doula care here in Georgia. And so they found through their study that the ideal price that doulas are asking for this type of services is 1,400. So I just wanted to highlight that that's the desired rate, and that's similar to what we see in Oregon, where they provide the same kind of services. They're doing reimbursement through Medicaid, and they get reimbursed at 1,500 per pregnancy for the same type of model. So just to give everyone an idea of what compensation looks like. And then we'll talk a little bit about motivational factors. So clients were eligible to receive a perinatal care package valued at $100, and they could choose between a baby care or a postpartum care package. So clients, when they completed care, told us what their preference were, and we got that sent out to them. And then doulas were provided a care package as well, and any HMHBGA references, like resources and pamphlets to give those additional resources to their clients. And then they were also given a $50 gas card. And then if they were willing to travel further outside their region, they were also given additional gas cards. So just want to take a second to pause and see if anybody has any questions based off implementation, anything we've talked about so far before we get into the findings, the data side of things. So just want to pause. If you have any questions, please put them in the chat and Madison will moderate for us.
Yeah, so our first question was how long were the visits? And then they said 60 minutes. So I can take the beginning of that. I would say it very often varies throughout our
Yeah.
clients. I think, Destiny, you're welcome to expand on this a little bit. But my initial answer is that it varies. Those prenatal and postpartum appointments can often be really brief and just a check in if the client isn't needing anything, but also can be a bit longer depending on the needs of each individual.
Yeah, I totally agree. I think just like reading through all the reports and stuff, it really varies. There's times where, and I'm sure if we could take people off mute and doulas could chime in that were in the pilot, they say as well. I'm sure there's times where doulas visited a client and went to their home and they had really good discussion and that lasted for 2 hours, right? There may be times where it was a virtual visit and it may be a lot going on and it lasted for 30 minutes. So I really think it varies, but I will say that the doulas were very um, like open with their time and how they were able to meet the needs of their clients.
Someone asked, and you kind of spoke to this already, were all visits in person or were there virtual visits?
Yeah, so it varied as well, depending on the client's needs and their preferences. Some clients, really wanted that in-person engagement, and so they did have those in-person visits, and that could be at the home or a Starbucks, or sometimes doulas even went to doctor's appointments with their clients. So there was those opportunities to do in person, but also maybe virtual if like they had to do a visit late at night and wanted to, do it virtually, or if there was any transportation barriers, virtual was also there as well. So it varied. It's the short answer.
And I know you'll probably speak to this a little later, but another question that came up is how many doulas were you able to recruit for this program?
Yeah.
And another one is, did clients have the same doula for prenatal and postpartum and their labor and delivery?
Yeah, those are really great questions. And I think it's about 40 doulas that were in the pilot. The exact number will be coming up shortly. So just stay tuned for that. But as far as same doulas, that also varied. Most of the time, yes. Clients were assigned a doula through that matching process and developed that relationship and rapport with their doula and kept them throughout. There were times maybe where a doula was providing support for another client at the same time that another client. So we did have some backup doulas that were able to come in and support in that way. Or if anything else happened, like if there was any other preferences or anything like that, it may have changed, but typically, yes, they kept the same doula throughout that experience.
Yeah, and then the next question is, I'm going to skip around a little bit and we're going to save some of these questions for the end because I think they're fruitful and are going to want to see the results before we dive fully into them.
Yeah.
So, were doulas paid as each service was completed and then paid again after labor and delivery, or one lump sum at the end? And that may be a question for our implementation team, but I'm not sure if you know off the top of your head how that reimbursement happened.
Yeah, I can kind of answer that a bit. And so I know that after doulas completed a visit, and also if there's any doulas that were in the pilot that want to like say their experience in the chat, please feel free. But my understanding is that after they completed a visit, they would fill out a form that said they completed it, and then they would be reimbursed by our team. So they should have been reimbursed after each service they provided.
Perfect. And then another question that came up is, were community-based doulas consulted when deciding on the original compensation rate for the pilot, and to what extent were they involved in other aspects of the pilot design? I will say that we have a handful of doulas on staff, And one of them, Chanel, is unfortunately having some technical difficulties and unable to join us, but she is in the chat. So she's going to be answering these questions as well as they come up. But she was involved in creating the implementation of the pilot. Again, the Georgia Doula study that Destiny referenced that helped us come up with compensation was also informed by community doulas. And we also had doula meetings monthly to integrate doulas with our team to say, is this working? What maybe needs to change? And Destiny can share a little bit more about that when we talk about the pilot findings. So we really tried to base our kind of implementation plan, have it change based on the input of the doulas that were willing to give their time and efforts to the pilot.
Yeah. And I will say, like, Chanel is a doula herself. So, a lot of these people that we've listed here that were on the implementation team were also doulas and, have their own businesses outside of this work. So they were really able to come to the table and, discuss what they were being compensated in their businesses, and, what that compensation rate looks like in their doula community. So I will say we definitely reached out to get an understanding of the desired amount. Yeah, and then we've doing continue to do research through the Georgia Doula study and just looking at what other states are reimbursing as well to help inform that.
We also have our CEO, Kai, here, who I've made a presenter. Kai, if you wanted to unmute and share a little bit more about the beginning of the pilot. I know you were kind of there at the start, and Destiny and I had to kind of come in on the back end a little bit.
So first, let me apologize. I'm actually nursing of the flu at home. So if I sound a little scratchy, that is why. However, this pilot was a brainchild of the Georgia Doula Access Working Group, which has had at any given time representation from at least 20 to 30 community-based doulas. OBs, even at times pediatricians, lactation consultants, et cetera. And we did a national normed scan at the time when we started to develop this. And that was even before me, about 3.5 years ago, to understand what those rates looked like. And it was variable. So if you want to nerd out a little bit, I encourage you to go to the National Health Law Center, who's been tracking a lot of the national efforts. But when I came, I mean, the rate was originally $350. And we were trying to be creative about how we can get those services to those participants with such a low rate. But thankfully, with a lot of advocacy and working directly with the payers, we were able to get that rate increased to $700 and even offer additional incentives, which I'm sure the team will talk about a little later. But a whole lot of thought was put into the rate amount, taking into account what private pay looks like, what private insurance looks like, and then understanding the reimbursable infrastructure, leveraging Medicaid. So just, you know, reaffirming that we've put a whole lot of thought in it. And when the evaluation team talks about findings, you'll see some additional recommendations reflected there.
Thanks, Kai. And Destiny, I will go ahead and let you continue, and we'll circle back to some of these questions at the end. Chanel's going to be engaging in the chat and answering as many questions as she can. So feel free to continue to ask them, and then I'll kind of save what's left at the end for us to circle back.
Perfect. Alrighty, part two. We're going into the data. Super excited to talk about that. So we'll split it up a little bit. We'll talk about some of the quantitative data, and then we'll do some of the qualitative data, pulling some quotes from the interviews we did with clients and doulas, and then we'll wrap up in a bit with some next steps, some recommendations. So we'll get started. So first, I want to just talk about how we collected our quantitative data. So we collected data from clients, doulas, and also a few health insurers. So starting with clients, we did exit surveys, and we'll talk about the ratings here in a bit. But those exit surveys just gave us an idea to better understand clients' experiences with their doulas. And a lot of the questions were on a scale. So it's like from 1 to 5, how would you rate this? So we have some of those ratings to present in a bit. They also had a client intake form on on-job form, which we talked about earlier, that allowed us to match with doulas, that just talked about where they were in their pregnancy, any preferences, any history that needed to be reported. And so they also did a health history survey in client records, which the doula completed in HealthView X, where we kept a log of every visit, any concerns, and things like that. And so doulas filled out a recruitment application on Google Forms. They also did debrief forms. So the debrief forms were kind of like the exit surveys for doulas. So after they provided care, they gave us a little bit of information on how that went for them. And we'll talk about that a little bit as well. And then just want to reiterate that they logged all of their health records on our HealthView X system. And then a couple of health insurers filled out some surveys based on their thoughts on reimbursement and doula care via job form. And then just some demographic data. So I want to say that this findings are for clients that completed care at the end of last year. So that is 123 clients. We have some more that have completed care recently, and we'll release findings for our total sample in the summer. But this is for that first 123 clients. And so the average age was 30.7 years. 72% of clients were Black, 94% spoke English, 93% were urban residents, and then 73% received labor and delivery support. So we see that 66% received prenatal support and 47 received postpartum. So that could vary for many, many reasons, but I think what that says here is that they really valued that support of doulas at their time of labor and delivery. And so doulas, yes, the number is here. It's 46 doulas that were engaged in the pilot. 80% were Black. And then we have a breakdown of the perinatal regions that they served. Mainly we're in Atlanta with 78%, but we do have some doulas that served out in Savannah, Macon, Columbus, Augusta, and Albany. So hitting those other areas. And then we had some insurers that completed the survey. We had one from Amir Group, two from CareSource, and one from United Healthcare. So just talking a bit about live births, 90% of clients preferred a vaginal birth and 10% preferred a C-section. However, 58% of clients gave birth vaginally and 42% gave birth via C-section. And we see some of the reasons here for C-section include the main one was fetal distress, but some other ones were failure to progress, hypertension preeclampsia, and breech position. And so births took place all over the state at 25 hospitals, but they were mainly at Emory University Midtown and Northside. So a little bit about client mental health. So according to those doula debrief forms that we talked about a bit ago, the largest challenges that affected clients' mental health were PMADs themselves and lack of support from their families. I mean, we just pulled this quote here to talk about how clients felt about their mental health and how doulas were able to assist with that. So it says a doula is a person who helps you with practicing to have a smooth labor. Try and bring you as much comfort during your labor and postpartum, helps you with your mental health, your emotional well-being, and just your overall self-care. So we just see here how doulas were able to help, support their clients' mental health and help them out emotionally. And we'll dig a little deeper into that when we get to the interview findings, but just wanted to place here like how doulas were able to support their clients' mental health. And then we have those client exit survey findings. So we just pulled a few here. Just want to highlight some. So there was a 4.8 out of 5 rating for the statement, my doula was supportive of my cultural needs. And we thought that was really amazing because I know in the beginning we talked about looking for those culturally competent doulas that provided culturally competent care. And so we see here that the doulas in the pilot were supportive of their clients' cultural needs. And then we also have a 4.8 out of 5 rating for my doula encouraged my participation in decisions, a 4.7 out of 5 rating for my doula respected my ideas and choice, and lastly, a 4.6 out of 5 rating for my doula made suggestions that were helpful. So this just gives an overview of how clients viewed their doulas and how they were able to help support them, encourage them, respect them. And then also our lowest rating was a 3.4 out of 5. And that statement was, my doula adequately collaborated with my doctors and nurses. And so some of the reasons there may be, there was some COVID-19 hospital restrictions. And so sometimes if a client was only able to have maybe one support person or two support persons there, they may have chosen their mom or their sister or their partner to be there, and doulas were there providing that virtual support. And so maybe they weren't able to, to be there to really collaborate with doctors and nurses. But other reasons may be, provider hesitancy. Sometimes because of how doulas are treated in those settings, they are a bit hesitant to really collaborate with doctors and nurses. And we have some quotes in a bit to kind of talk about that relationship with providers, that doula provider interaction. But we suspect that there's a lot of reasons why this rating would have been our lowest rating. And then next, birth outcome. So we have this kind of broken up here by birth givers in the pilot, birth givers in Georgia, and Black African American birth givers in Georgia. And I'll explain why in a sec. But we have here percent low birth weight is 12% in the pilot, percent premature births, 14% in the pilot, and percent births breastfed, 87%. And so we see here that our numbers compared to birth givers in Georgia, our low birth weight is a bit lower as well as our premature birth rate. And we see that our breastfeeding rate is a little higher than what we have here in Georgia. And then the last row shows what it looks like for birth givers in Georgia that are Black or African American. And so we see that and we talked about this in the beginning, those disproportionate rates. And so we see here that Black givers in Georgia their rates are a little higher than the average in Georgia. But we want to compare that to our birth givers in Georgia. I want to highlight that most of our clients were Black. It was about 78%, I believe. And so we really want to look at those numbers in comparison to our target population and who we served. And so we see our numbers in the pilot are comparable to those numbers and a little better, we see. So just wanted to give an overview of what this looked like for our findings in the pilot. And again, this isn't everyone we served, but our birth givers in the pilot, what this looks like for people in Georgia and also for Black birth givers in Georgia. And then we have some of the common breastfeeding challenges down here that were difficulty latching, baby in the NICU, and any medication concerns. And then we also have the average APGAR scores at 1 and 5 minutes, were 7.2 and 8 respectively. And then we're going to talk a little bit about the reimbursement process. And I know we talked about that earlier, talking about compensation. And if you have any additional questions based on this about the way they reimburse, I know Chanel's in the chat, and if anybody wants to ask in the Q&A session, we're happy to answer. But 85% of the doulas in the pilot reported that reimbursement process was easy, which is really great. And 76% of doulas in the pilot reported that they were reimbursed in a timely manner. And this statement was for within a few days of conducting my visits with the client. And so I want to say that the normal reimbursement rate through reimbursement time through Medicaid is about 30 days. And oftentimes we were reimbursing like within a week. And I want to highlight too that the reimbursement team consisted of two people, Chanel and Deandra. So they really did a phenomenal job at reimbursing doulas as soon as they could. So we do have positive ratings here with the reimbursement model that we did. There's many other reimbursement models, but we directly paid our doulas. So that's how we reimbursed here. And then some of those insurer survey responses. So 100% of insurers reported that doula services are very valuable for Medicaid clients. So they were aware of the value that doulas bring. And some of that included lower risk of maternal morbidity and mortality, lower risk of infant morbidity and mortality. And they also reported some of the challenges that they may have with that reimbursement structure. And some of that included identifying eligible doulas and also some administrative barriers. So we just wanted to really get their insights on what they thought about this doula care and the reimbursement process. So qualitative data collection and results. And so just a little bit about how we collected data. So we did some semi-structured interviews with clients and doulas. They were either on Zoom or on Teams, and all of our interviews were recorded. We had a transcription service, and the data was cleaned by our research team. And interviews varied from about 40 to 60 minutes, and we'll talk about the demographics as far as how many doulas and clients we interviewed in a bit. But for the doulas, there were also these semi-structured group check-ins, and talking with Chanel, we like to call them motivational empowerment sessions where doulas were able to come monthly, talk about any problems or concerns that they were having in the pilot. Also encourage each other. I am not a doula, but um, I know that some doulas can say that during these moments they were able to really encourage each other in the work that they do. And these things occurred, and we were able to transcribe these and clean these. So it gave us a lot of data to understand any problems that came up in the pilot, like with any technology or anything like that, anything we could troubleshoot, but to also just, understand their experiences through the pilot, which is so important. And they were able to encourage each other. So yes, it's a semi-structured check-ins, but they were much like empowerment sessions. And so going into the demographics of the clients we interviewed, so 17 out of 20 of them were based in Atlanta, 18, so mainly were non-Hispanic Black, but there was also two Hispanic birth givers that we interviewed and one white birth giver that we interviewed. And then the age range varied here, but most were in the 31 to 35 age group. And then some themes for the interviews that we'll dig into a bit. The first is empowerment and advocacy. The second is doula support for family. We also have emotional and mental support and resource and knowledge. We'll also talk about some themes from those doula interviews, and that included doula challenges, interactions with providers, doula recommendations, and perception of clients. So the first theme is support and advocacy. So through our interviews, we heard a lot about how clients felt supported and empowered and advocated for by their doula. And this is made clear by some of these quotes that I'll read today. And so the first says, "She made me feel empowered and heard. I felt like she was answering everything that I needed." Um, the next is, "I don't think that I would have been as competent as I was had I not had the extra voice in my ear. And had I not had the extra support outside of my family." She helped me getting a birth plan and being able to feel confident enough to communicate to my providers. Having that person, that extra person to answer questions and have any alternate aspect on things that family and doctors and stuff won't know, or I wouldn't feel comfortable hearing it from them. She made everything comfortable for me. And so this is hearing these quotes and, hearing about these themes that pop up is my favorite part of the presentation because we really get to see straight from the clients, their experiences with their doulas and how they were, able to feel supported and empowered and advocated for. So yeah, just some quotes from that. We'll dig into some more in our next theme. And so the next is emotional and mental health support. I know we touched on this a bit earlier, but just want to dig a little bit deeper into that. So a lot of clients reported feeling, emotional and mental health support from their doulas. And so the first says, "She just definitely provided just a safe space for me during that time of vulnerability that I didn't even know that I needed until now. I felt myself drifting away from it because of anxiety and everything. She helped me steer back into the right direction. I was just really, like, emotional the first days and trying to figure everything out. It's just that she was there helping me. She got me some help with a lactation coach, just being there, like, the early hours in the morning, and she just calmed me down and things like that, and coming over to the house, just being there for us." And so this makes me remember a question earlier about, how long would the visits be? And this is an example where I'm sure this was a lot longer a lot longer visits than others, but doulas were really able to come in and provide support where needed. And so this one, it shows that the doulas was there in the early hours and coming over to the house probably more than they, the two visits also. So just these quotes really just show how the doulas were able to be there for their clients and support them emotionally. And the next is doula support for family. So we see the doulas weren't just there for their clients, they were also there for their entire family. And so the first quote here says, she would be holding my hand in different things and rubbing my back. Then she'll ask, like, hey, dad, do you want to switch? Are you okay still here? To give him that relief, like, hey, I can hold mom's leg. So, really offering that support for the birth giver and the dad. And also, it looks like she's getting him involved here, right? Do you want to switch with me? So, helping that as well. Next says, as far as my spouse, she made sure that my spouse was included in everything and made sure that she knew everything that was going on. So, also offering that education to the dad. So, again, not just the birth giver, but the entire support system in that family. The last is she would check on us. She told me to relax, ask for videos from my fiance and some dad videos for experiences for new dads. And then next here we have resources and knowledge. And so this has come up in those previous quotes. We'll see like a lot of these themes intertwine, right? Because the last quote was how our doula provided support for the dad, but she sent him videos. So, it's a lot of these themes going hand in hand. So the first quote here says, she gave me a little book on breastfeeding. She made a little pamphlet and it had little points on there to websites and teach me how to breastfeed and how to handle and control my emotions when it came to postpartum depression. Um, and this is really great too, going out of her way to make little pamphlets. She was very educational as far as the knowledge she shared with me about what my options were, as far as pain management, simple exercises to alleviate some of the pain that I was experiencing. And lastly, we see that she was giving me resources and giving me alternate ways to help me calm down because I did form a good deal of anxiety and I was a little and having a little acid reflux and things of that nature. So we see that the doulas here were able to provide resources and be that bridge. I remember that statement earlier, be that bridge between the provider and the client and really providing those resources and offering knowledge. Um, and then next, we'll talk a bit about the doula interviews. So we have the race and ethnicity here. We spoke with two Black doulas and two non-Hispanic white doulas. 10 out of 12 of the doulas that we talked to served urban areas, but we did talk to two that served in some rural areas. And so we kind of have a breakdown here of that demographic. And so first we'll talk about some of the doula challenges. And so the first is, I guess they don't quite understand what I'm there for it. If they did, they would ask me to do more. They would like to be more involved. Some of them are standoffish. I'm not sure how they choose to get a doula. They like check a box. I don't know exactly, but I wish there was a way that we could educate them more on that. So this quote speaks to maybe lack of awareness by clients. Maybe they were paired with a doula, but didn't really have a full understanding of what a doula was and all that they could offer them. And so one of the pieces we'll talk about in a bit when we talk about next steps is just you know, making it more aware what doulas are, right? Really taking it upon ourselves to educate the community on doulas, of the benefits they have to offer, and how they can help improve health outcomes. And then the next is I think her biggest concern was that she did not want to be left alone, uninformed. She didn't know how to speak up for herself. And so we see here some of the challenges were the doulas, it was a lot for them as well. And they really wanted to be there for their clients as much as they could. And the last kind of speaks to the compensation piece, increasing the gas card. This says that would be great if you're getting these clients that are far away. The $50 for the appointment is only covering gas. So just that bigger discussion of how we compensate even for travel, if they're having to travel outside of their normal place. And so we did offer gas cards to doulas, and if they were willing to travel more, we were able to offer additional gas cards. But just speaking to that bigger conversation of compensation and how we can really compensate them for all that they do. And so the next is doula interactions with providers. And we'll see here based off the quotes, there's been some phenomenal experiences and not so phenomenal experiences. So I'll start with the positive one, which is our second one here. And it says, They were phenomenal, to be honest. They let her labor the way she wanted to, fairly throughout the whole process. Even when they were starting to see that she was having, it looked like almost a small hemorrhage, they were on it very quickly. It wasn't bad. They honored her delayed cord clamping. They were actually really, really good. So we see here that this doula had an amazing experience, at this particular setting with this particular team. But we see that that varies. Like the first quote here, it says, I think every doula at some point encounters a hospital staff that is less than welcoming. I think I don't know how to change the stigma that's out there about doulas. It just seems it's across the board. And any hospitals that I've gone to, I've had to help them to see me as a support person and not as someone trying to tell them what to do. And so we see here the experiences that this particular doula had with providers. And we'll talk about that a bit, really getting hospital buy-in and provider awareness around doulas and how we can improve that relationship and communication. This also is a barrier that may have impacted some of our exit survey scores that I talked about a bit earlier. Maybe there was some hesitancy. Maybe a doula had a less than welcoming experience. So maybe they were hesitant to step in and really work with providers and collaborate with them. And so we see that there's been some varying experiences, but I do want to highlight that there has been some really great ones and not so great. But we're thinking about how we can help build those relationships. And then next is doula recommendations per provider. So kind of going hand in hand with the last theme we talked about. And so it says, I guess just being gentle when you ask them questions, because sometimes mom or the family doesn't understand what's going on. So you're asking questions so we can explain what's going on. The next one says, that's whimsical right now. It's like a fairy tale because it will require that they stand beside us. I feel to truly respect our practice and what we do, you have to some degree respect the spiritual aspect of birthing and how we bring. We help to bring forth life in the sense that sometimes we carry, we help the mother, we literally get behind her and hold her stuff up so she can move on to the next phase of her experiences, whether emotional, some people are physical laborers and laborers of love. So this just gives, a quote of that they think that it's not possible at the moment, but that it will require them to stand by us. And, it just gives also just an overview of what doulas bring and, their practice and that, other people should respect their practice. So I really like here that we're pulling these quotes straight from the doulas, straight from the clients. And so you can really get an understanding of their experiences, their perspectives, and their thoughts. And next we have perceptions of clients' needs. So this just tells us a little bit about what the doula saw that the clients needed based on their interactions with them. And the first is the client has to travel quite a distance to deliver her baby because the hospital there does not have a maternity ward. I have not seen any birthing centers out that way, so it's not very baby friendly out in that area. And that speaks to what we talked about in the beginning, this lack of access, right? So a lot of the times when clients do live in counties where there is no hospitals around, they are having to travel a bit of a distance to make it to a birthing center. And so we see that here in this experience. And then we also have if they can offer more postpartum care or options, even if it's just the gas card or whatever for the NICU to go help the parents in the NICU. If they can add more prenatal visits, that would be great, where we can do more childbirth education. So here we saw that doulas felt like clients needed, more than what they were able to give. And we see these unique experiences like when they do live in rural areas or they are in the NICU, needing that additional support. And the last one speaks to that as well. And then we'll talk a little bit about the study limitations, right? So I'm sure, now that we've wrapped up this pilot where our minds are just like, where could we take this next? And how can we learn from this experience? And so the first is the matching process. And like I said previously, Chanel was very phenomenal and amazing with how she matched. But something that we've thought about is allowing clients to pick their doula themselves, right? So allowing them to see the different doulas and what they offer and what they specialize in, and letting them have choice of who they pair with. Also, we talked about this, the low reimbursement rate. So how can we increase that to be close to what doulas are in the state desiring for these types of services. Also, this hospital COVID-19 policies, I'm sure this isn't as much as a problem now currently, but when we were doing the pilot, there were some policies that did not allow doulas to provide care in the hospitals. Also, doula capacity. We want to be sure that we don't match doulas with too many clients so that they're able to really provide their clients with the care that they need. And then nextly, survey response rates. And so the insurer rates, we did get a couple, but we didn't get any of those provider responses that we hope to have. And so there could be a lot of barriers for that, that we mentioned, and maybe the hesitancy to reach out with the providers. But we'll talk about this a bit on our next steps, but really building those relationships and getting hospital buy-in so we can have an understanding of what providers think about this topic and how we can be better to build their awareness and how we can work together to provide the best care we can for birth givers here. And then we have, well, I talked about distribution and collection of medical surveys, and then a support group, control group. So we didn't have a control group in this pilot, which would be really amazing. So we could have a group of clients without doula support, and we're really able to compare what the difference in outcomes look like. And then public health significance. How is this significant? So doulas assisted birth givers with the opportunity to tailor their obstetrics care, to include cultural and therapeutic practices into an otherwise purely clinical experience. And our wait list consisted of over 300 pregnant Medicaid recipients. So that shows us that there's a demand for these services, right? Like, there's people that want these services. How can we continue to provide care to them? And so this pilot showed us that there is a demand out there, and there is a need for a significant research push to make more confident, empirically backed recommendations, as this was a pilot. So this was a pilot, and we do need to do, more research and continue to dig in this a bit deeper. And then next step. So what's next, right? So I've talked about all these things throughout. They've come up naturally, but just want to dig a little bit deeper into each of them. And so the first is increase awareness of doula care. And that's across the board to everyone, right? So increasing it to the community members so they can really understand what a doula is and how they're able to help them. There were so many quotes that I can think of in my head that we weren't able to put everything here on the screen today, but there was quotes that said, like, if it's available, I think every woman should have a doula, right? And so increasing awareness, because maybe someone may not know what a doula is. Where do we even go look for that, right? So increasing awareness out in the community, also increasing awareness among providers about who doulas are, what they're able to offer, and how they can work as a team to provide the best care for our community. Also, we're thinking about doing a pilot in a hospital setting that allows us to be there and get buy-in from the hospital system and buy-in from providers. Doing it in that setting. Also a control group, which I mentioned, and also a mental health component. And so we were lucky, really lucky, to naturally get mental health data here. Clients reported, if they had previous anxiety and depression or other mental health conditions. But we want to really do a mental health component and some intentional screening around mental health support. And we saw in the first couple slides that mental health conditions in Georgia are the second leading cause of pregnancy-related deaths. So really digging into this mental health component deeper and seeing how doulas can maybe help assist with any mental health conditions, helping to be that bridge and provide resources, just really doing some research and understanding that better. So next steps would definitely be including a mental health component. And that is it for now. I'm happy to keep answering any questions. I can't see the chat. I don't know what's going on, but Madison, if you wanna start that Q&A.
Yeah, sure. So I'll lift up a couple things happening in the chat. One being, Kai mentioned another next step is going to be our awareness building with systems players and legislators. So a really large portion of this pilot's outcomes we want to be able to take to the Georgia Assembly and share with them and create a space where we can educate on what doulas are and what potential avenues for reimbursement look like and what potential role legislators and policymakers as well as systems players can take in transforming the way that doulas are interacting in Georgia and the way that they're being paid for their services. So I just want to uplift that because that's another really great next step. Feel free to continue to drop questions in the chat. I'm going to scroll back and read a handful that we touched on already and be sure that we can get those answered. Let's see what else I did see. So one of the questions that came up that did kind of seem to get answered towards the end is, were doulas able to link clients to support services, food supplies as part of the scope of their services and therefore included it in the $50 rate? And I think Destiny touched on that a little bit since that question has been answered. It is included in that $50 rate, but we did try to provide gas cards for those who were potentially traveling further, as well as we had some thank yous and some gifts for our doulas that really helped to kind of supplement some of the needs they may have. I can say that we definitely were not able to reimburse enough for how much effort they put in. That one quote that Destiny showed, that I'm sure there were a handful of doulas in the process that were really going outside of the scope of what was in this pilot and making sure that they were there on the ground with their clients when they needed to. So, but a second piece of that is going to be linking to support services, linking to resources, food supplies, mental health resources, lactation consultants, anything that may come up for that family during that period of time. Another question that came up was, speaking to a situation that happened in Oregon, it says, regarding doula challenges, one of the ongoing challenges we see throughout Oregon is when clients forget or unable to call the doula when they go into labor, and then they flake out on those visits. So if a doula can only take a handful of clients a month, but then they aren't getting called in for that labor and delivery, are they potentially out a significant portion of that planned income? And they can't just schedule someone else last minute. So it sounds like this pilot had more prenatal visits. We did have only 2 prenatal visits, which is similar to Oregon's paying for 2, but is this something our doulas faced in the pilot? And so I think that my answer is yes. I'll let Destiny elaborate a little bit because she was a little bit more ingrained in that process speaking with the doulas.
Yeah, yeah. That did happen. There would be times where a client would be, rushing to the hospital and they wouldn't call their doula to come, right? And so, not only did the client not get the opportunity to have their doula there for labor and delivery, maybe not because of a restriction or anything like that, but they just didn't call. But also the doula missed out on $500, right? And so that's a huge barrier, right? Because if we're only reimbursing for the services that happen and they forget to call, maybe a doula is ready, but they can't do anything if they don't reach out. So yeah, that is a really huge barrier. And we have to, look into ways that we can help with that. um, yeah, yeah, that's huge because they miss out on that the biggest portion of the compensation that comes from that.
Yeah, and I think that's something that really comes up during pilots like these. It's those things that when you're trying to create a sustainable reimbursement model that
Mhm.
maybe don't come up in those initial conversations, but when you really start to game out these strategies, things like that come up and you recognize that we need a model that corrects for that or that provides space for that so that we're not so one, we're getting the most that we can out of the perinatal workforce, but while trying to obviously create a system where they're benefiting, they're being reimbursed, they're being paid for their time and services in a way that's sustainable and it makes a sustainable living for them as well. And so I think knowing that this pilot was far from answering those questions, but it definitely helped us to frame them a little bit more for what they look like in Georgia. I will say another question. Sorry, they're coming in. It says,
Great.
if collaboration was low between doulas and providers, what was the possible cause for higher than preferred C-section rates? And any suggestions for improving this aspect in the future? I know you mentioned the hospital buy-in or hospital pilot, but any suggestions in the interim? I can take kind of a little bit of that question. I think a really important part of this is that education building and is that advocation or is that self advocacy in the birthing space. So Healthy Mothers, Healthy Babies is really dedicated to creating spaces where we can teach mothers and birth givers how to advocate for themselves in the birthing place, to know what their rights around having a vaginal birth versus having a C-section versus potentially having a vaginal birth after having prior C-sections. I think there's a real lack of education on what opportunities and options are available. And the hospital buy-in piece and the hospital provider relationship piece is going to be really large in addressing those issues. But in the interim, other steps we can take is just really making sure that birthers are able to advocate for themselves and know what their rights in the birthing place are surrounding the way that they're giving birth, and the really implementing that birthing plan. Because I think, again, that's a problem that we didn't totally get to answer in this pilot, but that we were really able to flush out. Kai, yeah, I'll let you take it away.
Yeah, I don't want to scare anybody, so I'm not coming back on camera if that's okay.
That's
But one
totally
thing that
okay.
I think was really interesting to consider about the C-section rate specifically, I want to lift up that, 65 of the participants were high risk patients. And that was, due to an agreement that we had with one of the partners who supported the effort, which I think attributes to that higher rate of C-sections amongst the population. I'll also say though, like those COVID restrictions really impacted this pilot because conditions were just not normal. And I think it heightened what had already been hesitancy on all ends for that kind of collaboration, given a lot of those COVID restrictions. And I want to lift up one of our partners, Dr. Sarah Blake at Emory University, who kind of explored the psychosocial implications of COVID and pregnant peoples. And, you know, we don't have that data specifically reflected in this pilot. However, there's tons of research studies out there, whether it's from the clinician or the family, transparently, where there was just still a lot of hesitancy for engagement. And that kind of hindered that relationship building and that bridge building. So I love to say that we could point to one thing. Um, and I know what my gut will tell me just based off of some experiences with different hospitals, but I think it's so variable, and our sample was relatively small, and it makes it really hard to make those kind of inferences.
Yeah, I think that really speaks to one of the other questions that came up in the chat was, were there any differences in participating hospitals and their policies? I think that was a way that we weren't fully ready to analyze the data. And so when our white paper comes out at the end of this summer, we're going to be providing all of the data around each hospital and the outcomes. However, I think, like Kai said, there's so many factors, including the underserved population that was participating in this pilot, the fact that there were very high risk pregnancies at play, and the fact that it was during a time where hospital policies themselves were changing rapidly with the health crisis that was COVID. And so the answer is yes, but we aren't confident that we can make any conclusions on why that was or what that potentially means for the birth outcomes of our clients.
Yeah, and we did do a scan of, every hospital in Georgia, and tried to reach out to them. We did a search. Our team did a search on Google to see any COVID restriction policies. We called. We did everything we could to get as much information as we could to, equip ourselves and our doulas with any policies that were there. So we did do that scan, but like Madison said, a lot of those policies were changing very quickly during that time. So we'll be sure to dig a little bit deeper into that as we present findings over the summer based on different hospitals.
Yeah, and I think another question that someone just asked is, considering the fee average was about 1,400, how did the pilot's $700 impact doulas joining to support birthing people? I'm sure that that had an impact, and I can say that a benefit that we had in this pilot was that we worked with a group of doulas who were just so desired to serve in this space and so passionate to be part of this project. And so we really had to lean on that passion and lean on their willingness to serve in order to make this pilot come to fruition the way that it did. I think very often, as we saw in some of these survey responses, doulas were really willing to go out of the scope, provide their clients with the things that they need, even if we weren't able to compensate them. So I think, one, we really had to lean on the willingness and the kindness and the passion of those doulas in order to make this happen. But two, this is a space that very often isn't funded at all or isn't reimbursed at all or is coming straight out of a client's pocket. And so we really wanted to create an avenue that, even though it is not the perfect amount of reimbursement and even though it is not nearly as much as they're probably deserving to be reimbursed for these services, it was an avenue for them to make potentially more money than they would in the way that they're currently giving their doula services. And so we're hopeful that it provided enough of a offset to the typical experience of providing doula services in Georgia as of now, but also really, I mean, truly could not have done this without the doulas that were willing to serve. And I think that that kindness and that passion and that call to this work really played a part in our ability to staff it.
Yeah, yeah. We cannot like thank them enough for, everything they did. Like they poured everything, in it. I like again, I'm not a doula. I can't speak to all of this, but just from my experiences with talking to them, it's a lot on them as well, and they poured so much of themselves into their clients, and there's been times where doulas will spend a couple days at the 2 or 3 days at the hospital. It's like, how do you compensate for that? So they were really, really willing to go above and beyond what could ever be asked of them to really be there for their clients and their families. So we cannot thank them enough for everything that they did and are continuing to do.
I'm scrolling to see if there's just a lot of lifting up the incredible work of our doulas in this pilot. A shout out to Chanel and her
Yes,
team.
yes, yes, yes.
Yes, for the self-care, and they really work to create, like Destiny said, those spaces monthly to really talk about what experiences were coming up. But we also tried to provide gifts and reimbursements as much as possible, because again, could not have done it without them. I'm scrolling to see if there's any other questions. I know that things happened in the chat really quickly, so if there was something that I missed, please feel free to repeat it in the chat. I see, are there any more pilots like this one on the horizon? And Kai's immediate response is, if we can get funding, with the big haha. I think it is the passion of almost everyone involved in this pilot, if not everyone involved in this pilot, that there will be more pilots and more ability to reimburse, and even some potential policy and programmatic changes that can help to create similar spaces, even outside of Healthy Mothers, Healthy Babies Coalition of Georgia. Kai, I'll let you go ahead.
Yeah, first, I want to give roses to both of you. This has been incredible. Full transparency, like, this is my first full presentation with the team, and I just can't thank them enough for how dynamic this went. Secondly, speaking to kind of not only the future of this work, from a reimbursement perspective, but also overall perinatal workforce endeavors that our agency is supporting. One, we have our Georgia Doula Access Working Group, which is this amazing think tank of individuals who came together with three specific charges, the biggest bucket being that reimbursement for doula services, the second bucket being workforce. We need doulas who are doula-ing. Otherwise, we'll have this wonderful reimbursement infrastructure and not a lot of folks who can go out and provide services. And then that third piece is around just awareness building for all directly impacted individuals, whether that's birthers, their intimate partners, their support systems, and others, but also systems players and clinicians, et cetera. I think there's this misconception that doulas catch babies and they are midwives, and there's like a lot of nuance between all of these different perinatal professional pathways, and we want to build clarity around that. And I think many of you will appreciate doulas are kind of a hot topic right now. So we want to both embrace that, but also humble us in realizing that it's going to take a care team to solve the health disparities that we're observing, specifically in Georgia. And it's not replacing anyone, but adding to the supports that we have available for families, particularly those with limited resources. I say all that to say, we want investment, certainly, in replication of this pilot, but the end goal is to have a fully adopted policy or infrastructure recommendation, whether we lean on direct pay kind of mechanisms like in Florida, where we just work with the payers, right? It makes it a little bit easier, but then, there's a lot of nuance there. Or if we work directly with DCH. There's just a whole lot more from a systems building standpoint that we want to understand better. And we appreciate everyone across the nation who has been really helpful in helping us be thoughtful about the recommendations that we put forward to our investors in the legislature. As it relates to who supported this, we were very lucky to cobble together our rubles from several different agencies, including a couple of payers, so United Healthcare, CareSource, and AmeriGroup. Also, shout out to Healthcare Georgia Foundation, who basically was like, we want to support doula stuff. Here's some money, do it. I need more funders like that. Shout out to them. Also, thanks to some of our relationships with academia, Georgia State lent their expertise in helping us sophisticate our evaluation. As you know, there's a lot of power dynamics at play. And because this was led by and centered for those directly impacted, we wanted to make sure that the individuals who had their eyes on this knew doula work inside and out, and were able to, evaluate the pilot in that way. So we hope that we're able to, continue to move this work, replicate this pilot, yes, but I think the one thing that I'm most proud of is how we were able to leverage this to get some gap filling resources for doulas. I sit on the board of the Atlanta Doula Collective, shameless plug, right? And those ladies are doing the work for free. That is unconscionable. And we were recently awarded dollars to create a safety net fund to support doulas for offering services to those under-resourced communities so that those doulas can continue to do the things that they're most passionate about for the individuals who desperately needs those services, but they also getting paid what they certainly deserve. And I appreciate charity, but I'm not about, people putting blood, sweat, and tears and not being honored for that. And I will say that the safety net fund is not quite at $1,400, but it is 1,000 for that same level of services. So we're inching towards, that gold standard, while simultaneously pushing for additional reimbursement rates for midwifery care and having midwives be able to practice within their full scope, as well as clinical support, et cetera. So that was a long answer, but hopefully it was helpful.
Thank you so much, Kai. And Destiny, I will pass it over to you to kind of run through those last few slides and resources that you had to share.
Yeah, of course. So current doula research in Georgia. So Dr. I'll go back a slide because that's a lot to look at. Dr. Mosley, who is not here with us today, was a huge help in this pilot, and she is a researcher, and so she and a doula herself, right, Madison?
Yes.
So she really has been doing some doula work, some doula research here in Georgia. And on the next slide, there is a list of publications that have come out of that Georgia doula study that Madison talked a little bit about, to really understand what doula care looks like here in Georgia. There's some papers about COVID. I think Kanaya was on the call, but her thesis came out of that study and it's on this list as well. And she helped out as well with this pilot. So there's been some amazing research being done if you want to look more into that. Until the next slide, we will send the slide deck out. I wanted to highlight there's some information here, a bit about how I talked about earlier, the different reimbursement rates and what Medicaid reimbursement rates look like across the nation. So be sure to check that out if you're interested in learning what that looks like. And then also this fourth one, and you can click on all of these, is a link to a news article that has a video in it as well that's really beautiful, and it is a pilot, a participant from the pilot and a doula from the pilot sharing their experiences. It's really amazing, really beautiful. So if you want to check that out to kind of, see what that looks like straight from some people that were involved in the pilot, please be sure to do so. And then here is all those publications from the Georgia Doula study. So like I said, we will be sure to send this out. This is a short list of resources, but just wanted to provide provide everybody with some things that they can look at after this presentation is over to learn more about what's going on here in Georgia and across the nation with doula care. And if you have any resources to share with us, we always want to learn more, understand more, dig into this topic more. We're all very passionate about it. So if you have any resources to share with us, please do so. But this is just a few that we wanted to provide to you.
And I also really quickly want to take a minute to go ahead and plug our Doula Access Working Group as well. Anyone who is not part of that working group but thinks that that could be a good fit to join, feel free to reach out to Destiny or myself and we'll get you connected with Chanel, who runs our Doula Access Working Group. That's going to be meeting 4 times a year, but we're going to be potentially ramping up meetings and talking about how we can create subgroups to dive into some of these next steps and issues that we've been talking about today. We really want to create lots of spaces to be having these conversations. And so whether you're a doula or a provider or just someone who really wants to get involved in the next steps, feel free to reach out to us so we can get you connected with that working group and have you work alongside us.
Yeah, and we'll be sending out, we have everybody's emails that registered today, so we'll be sure to send out the slide deck, any, contact information for myself, Madison, and Chanel, ways that you can get more involved with us in this work. But I just want to say, I'm sure Madison or Kyle have like final closing remarks, but I just want to say thank you for being here, for your time today. It's a privilege to be able to present this to you all and to talk about what I've been, helping be involved in for like a year or some change now. I started out as an intern involved in this project, and I completed my internship like for school requirement. And at the end, I was like, I have to see this through. Like, I can't leave now. Like, I'm too involved. So I like reached out to Kai. I'm like, please, you don't have to pay me. Just let me stay around. And she was gracious enough to let me stick around and still intern for some time. And I now work here full time. And it's a privilege to be able to see this project all the way through. And I'm so excited for the future and so appreciative of the conversations that we've had with doulas in the pilot and participants and, everyone that helped out with this. So thanks everyone for being here today. For me, I'm so excited, to share this with you all and for what's to come. But I know I'm going to pass it over to Kai Madison for any closing.
Yeah, I will wrap us up just with saying I don't think I could say any of it better than Destiny just said it herself, but we do have an amazing programs and amazing research team who backed this project. And I'm just really, really grateful to you, Destiny, for all of the really hard work that you put into not only the evaluation of this project, but the phone calls, the presentation, the many hours that we spent trying to get this information out there. So thank you. You're amazing. And also, I wanted to highlight that all of our findings can be found on our website under our research tab. I will go ahead and drop that in the chat for anyone who's looking to reread these findings before this pilot comes out, and our white paper will be coming out towards the end of the summer where we dive a little bit deeper into the analysis of some of these issues. So we can't wait to share it with you, and we're so thankful to all of you for being here today. And that's a wrap.